PRK and cross-linking. Thank you so much, Guido. Thank you, Master.
And guests, I'm going to do my speak in English, okay? So, a brief excursus on keratoconus correction. So, what we have to do in the early stage. The first treatment is spectacle lens and contact lens, as you know. Now, in the last 10 years, it's going to come the new treatment of cross-linking in the keratoconus that are not still evolved. So, and the cross-linking, as the previous speakers told, was epi-off and accelerated cross-linking. The effect of cross-linking is very common. No, everybody knows that UVA with riboflavin cause cross-linking reaction of the collagen fibrilla of the cornea. Increases the biomechanical stiffness and the stability of the cornea itself. So what we have to do for the medium advanced stage with the clear cornea and the contact lens intolerance, with severe corneal irregularity, high irregular astigmatism, and high order aberrations. So we have this device that we can do, the ICR intracorneal rings, or the more severe cases, corneal grafting, or in the other case, PRK, aberrometric photorefractive keratectomy. And we can do combined technique, so PRK plus cross-linking, ICR plus cross-linking, and the triple procedure that I'm going to speak about, intracorneal ring plus customized PRK plus cross-linking. So in the literature, there is a lot of article about the use of intracorneal rings and the safe use with the femtosecond laser, and the efficacy to reduce the coma aberration in the plus more than 3 microns. So what is the ICR effect? So they insert the rings, separate the corneal lamella. The separation shorter corneal arc length, so there is a central corneal flattens. Increased flattening achieved with thicker segments. So the more is thicker the segment, the more is the corneal flattening. We implant the rings at 70–80% of corneal thickness in the surgical site. If what's going to happen is too shallow, we can have epithelial defect and extrusion of the rings in itself. If it's deeper, we have poor refractive effect. So on the market, we have Intax, Ferrara ring, Caron ring, and Mayo rings. We can use PRK for treat keratoconus. Yes, there is a lot of article about this. What is done? PRK allows to flatten and regularize the cone with improved vision quality, but the aim of aberrometric treatment improve the visual quality and not lead to independence of glasses. So we can max treat not more than 50–60 micron. We have to treat the high order aberration, especially the coma aberration, the third order. If we have enough tissue, we can treat even a sphere defect and 50% of cylinder defect. We use optical zone maximum 6.5 millimeters. We use same-day cross-linking to stabilize the result. So there is an article in the literature about these treatments, and the same-day simultaneous topographic guided PRK and cross-linking appears to be superior to sequential cross-linking with the later PRK, according to this kind of literature. But the what is the combined surgery technique? It consists in first inserting the rings, wait 4 months, and that stabilizes the situation, and after 4 or 5 months, in the same day, aberrometric PRK plus cross-linking in the same times. It shows important improvement of the visual acuity. As you can see, in the 71% of the cases, according to these articles, we can gain 3 or more line of Snellen of visual acuity uncorrected, and 24% we can gain 3 or more line of Snellen in corrected visual acuity. Why this kind of technique? To stabilize pathology and improve quantity and quantity and visual quality. So I use Intacs usually to reduce corneal irregularity, to decrease the cylinder defect. After 3 months, in the same time, I make customized PRKs with a topo-aberrometric linked and accelerated cross-linking. When we can do this kind of procedure? After we have to wait that the keratoconus is going to be a little more stable, so usually after age 28. The stadium of keratoconus must be the second, third stadium with with the visual acuity around more 4, 5, 10, and pachymetry more than 450 microns. I want to show you one case, female, age 40, keratoconus second, third stadium. As you can see, the visual acuity was not so good, and there was a lot of quantity of high order aberration. Okay, you see the refraction over there after the Intacs implantation, and this was a follow-up of 1 year. So that was one of my first cases. And see the quantity of the astigmatism was reduced after Intacs implant. And see, as you can see, after 8 months after transepithelial PRK and accelerated cross-linking, the result was pretty good. So in the OD, the visual acuity reached 20/20, and in the OS, almost 20/25. So we can see that this procedure is pretty useful to treat the keratoconus in the second, third stage, instead of or before or trying to avoid corneal transplantation. So it seems to be a valid option, but further study will be necessary to confirm it. Thanks a lot to everybody.